So today's topic is pre-transplant urologic malignancies, wait time to transplantation, and kidney transplant outcomes. And we face this problem a lot while evaluating patients to list them for a transplant. Don't have any disclosures. So the objectives are discuss pre-transplant wait time in patients with a history of indolent cancers, analyze the outcome of kidney transplantation in patients with prostate and kidney cancer, explore cancer risk in end-stage renal disease patients and transplant recipients. So I start off with a case. This is a 69-year-old man, pre-dialysis. He has a potential living donor. He comes for a kidney transplant evaluation. He has good functional capacity. His other workup is fine. His PSA is 6.82 with the reference range over there for age. And then patient is discussed and deferred due to elevated PSA pending urological evaluation. He sees urology October 2022. They perform a digital rectal examination. They don't find a nodule. They say repeat PSA in 6 to 8 weeks. If it remains elevated, then we'll perform a prostate biopsy. So he gets a transrectal prostate biopsy in December 2022, and they find that there is a Gleason 3+3 grade group 1 stage T1C localized prostate cancer, and 11 out of 12 reports were negative. Patient refuses radical prostatectomy, so they put him on active surveillance. He gets another confirmatory biopsy June of 2023, which shows stable disease, and time lapsed since initial evaluation is 20 months. So would you now approve him for a transplant or wait further till he accepts treatment? So the questions and concerns we have are: what are appropriate wait times before transplantation in patients with a previous history of cancer? Is it appropriate to transplant patients with active cancer? What is the risk of cancer recurrence, progression, related mortality post-transplantation? And how does immunosuppression affect outcomes? So when we look at wait times, the largest study in transplantation is by Israel Penn. This is a study of 939 pre-existing malignancies that occurred in 913 kidney transplant recipients. And they found that the overall cancer recurrence after kidney transplant was about 22%. Wait time of 2 to 5 years between treatment of cancer and transplantation was advised at that time. They divided the cancer into low, intermediate, and high recurrence cancers. Even at that time, they said that no wait time was recommended for certain cancers. They also found that the more you wait after the last cancer treatment before transplanting that individual, the recurrence rate would drop. So currently, apart from this other study, recommendations for kidney transplanted patients with previous cancers are derived from data of cancer recurrence in general population. Cancer-free wait time between 0 to 5 years from the last treatment is recommended by clinical practice guidelines. A 5-year cancer-free survival of 80% is acceptable benchmark for listing. Now, we know that there is a definite mortality benefit to transplantation. And why is this topic important? Because cancer after transplant is the second most common cause of mortality in transplant recipients. This is a study from Australia and New Zealand dialysis and transplant registry, which showed that the cumulative incidence of cancer at 20 years post-transplantation rose up to 40% for all cancers, including 15% for solid organ cancers. Now, the malignancy risk in transplant recipients is expressed as the standard incidence ratio, which is defined as the incidence of cancer in a specific population of interest, which is transplant recipients, as compared to the age and gender matched general population. So this is the standard incidence ratio of various cancers from registry and multi-center studies across the globe. We find that the Sanders incidence ratio for certain cancers is low as compared to other cancers. And there could be various reasons for this difference across the globe, including data collection and differences in the age and sex match population, or there could be a true high incidence of cancer in a particular referenced population. So essentially, the risk of cancer development after kidney transplant depends on the cancer types. It is higher for certain cancer and it is lower for certain cancers. Now, what about the mortality? So this study looked at overall site-specific cancer mortality in patients on dialysis and after kidney transplant. So this was a study. This study looked at close to 53,000 dialysis patients and 17,000 transplant patients. And what they found was that both dialysis and transplant patients experience a higher risk of cancer mortality as compared to the age and sex matched general population. But there were particular cancers with higher standard mortality ratio. In dialysis patients, there were multiple myeloma, testicular and kidney cancers, whereas in transplant patients, there were non-Hodgkin lymphoma, kidney cancer, and melanoma. They also found that there were more deaths due to pre-existing cancer in dialysis patients as compared to the transplant patients. More transplant patients died due to de novo cancers rather than pre-existing malignancies. Now, when adjusted for non-cancer causes of death in dialysis patients, again, standard mortality ratio was highest for multiple myeloma, lung, and kidney cancer. And for in transplant patients, it was highest for NHL, lung, colorectal, melanoma, and kidney. So again, the overall risk of cancer-related death is higher for certain types of cancers as compared to the age and sex matched general population.
So is there any data about not, for transplant to use the CKD population rather than the general population? Comparing it to
Yes, exactly. I was coming to that in the next slide. Yes, exactly. So this is another study which actually looked at mortality in incident maintenance dialysis patients versus incidence of solid organ cancers. And they found that the long-term survival probabilities of certain cancers was actually better than being on dialysis. So like you have pointed out that this standard incidence ratio, which expresses the risk of cancer compared to the general population, it could be of limited value when you are evaluating transplant patients. When you are evaluating patients for candidacy, the relative risk of cancer development post-transplantation should be compared to the risk of developing cancer while on dialysis or CKD. And the relative risk of death due to cancer post-transplantation should be compared to cancer death while on dialysis. So to answer your question, there's not much data. So this is the belief that more men die with prostate cancer than because of it. So this is data which looked at autopsy detected prostate cancer in men between 20 to 90 years of age, and they found that the prostate cancer prevalence was 21%. The prevalence of autopsy detected prostate cancer was greater than the disease specific mortality in all age groups. And they also found that, as you grow older, your chances of having a higher grade prostate cancer also increases over time. So what about survival in patients with prostate cancer when they are on dialysis versus when they get a transplant? So this is a retrospective study coming out of Cleveland Clinic, which matched ESRD patients with prostate cancer to the same number of controls without prostate cancer. They excluded patients who died less than 90 days before their first ESRD service date, or who were transplanted less than 90 days before their first ESRD service date. or they had cancer at or before their first ESRD index date. So what they did was they found patients on dialysis and then they analyzed it retrospectively, and at a point where they were diagnosed with prostate cancer, that point was what was the starting point. At that point, they were matched by 1:1 risk propensity matching to the same number of patients who did not have prostate cancer. And the problem was that, the patients who had prostate cancer were older and there were more blacks in that cohort. And the outcome was either time to transplant or time to death, which is all-cause mortality. They tried to look at the relative risk of all-cause mortality with or without prostate cancer in ESRD patients. They also tried to look at the survival benefits of patients with prostate cancer with or without transplant. So when they compared the Kaplan-Meier survival curves of ESRD patients with and without prostate cancer, they found that the median survival, which is in red, of ESRD patients with prostate cancer was lower than patients who did not have prostate cancer. And there was 11% higher likelihood of death from any cause in patients who had prostate cancer. Now, when they compared the survival of patients who got a kidney transplant, irrespective of their prostate cancer status, their survival was much better, 7.3 versus 7.1 years. So they found that there was a definite survival benefit of an ESRD patient with prostate cancer getting a kidney transplant. Now, this is the TNM staging. I would be referencing them in some of the slides. So I'm only talking about localized prostate cancer, which is either T1 or T2. So T2 is organ confined disease. This is a risk stratification, and I will only be talking about very low, and intermediate favorable risk cancer, which is essentially Gleason's grade group 1 and 2. So another question is, does immunosuppression negatively affect prostate cancer outcomes in kidney transplant recipients? So this is data from this is data from Sweden. So essentially the National Prostate Cancer Registry of Sweden had information about all prostate cancer diagnosis since 1998. The Swedish Renal Registry had data about all kidney transplants in Sweden beginning 1966, and the Prostate Cancer Database of Sweden had data from NPCR and other cancer registries. And in that database, one patient with prostate cancer was matched to 5 controls. So they did 3 separate analyses, and which we are going to talk about. The first one was they matched 133 kidney transplant recipients with prostate cancer to patients who had prostate cancer but did not get a kidney transplant in a 1:5 ratio. And they also followed the patients with prostate cancer and with the controls. So what they found was in 133 kidney transplant recipients, there were only 12 deaths from prostate cancer at a median follow-up of 9 years. 15-year prostate cancer survival was similar in both groups. However, the overall survival was 3.7 years shorter in kidney transplant recipients, probably because they were CKD and end-stage renal disease. So in 2 separate analyses, they try to find out the probability of developing non-low risk and high risk prostate cancer based off of your kidney transplant status, and there was no difference in that. The odds ratio were similar. They also try to look at the probability of developing prostate cancer over time in transplant patients. So, and the odds ratio did not increase over time. they realized that half of the kidney transplants were before 1990 when PSA testing became common practice, which meant that quite a few patients had been living with this low-grade prostate cancer for a while. And they suggested that active surveillance or even watchful waiting is a viable option for low-grade prostate cancer. Now, how about utility of prostate cancer in kidney transplant candidates? This study is coming out of Emory. It is a single-center retrospective study of almost 4,000 ESRD patients, out of which 1,200 were transplanted, and PSA screening was done in 63.6% of patients. What they found was that out of the 182 with a with a PSA of more than 4, only 48 were, or which is 26.4% were diagnosed with prostate cancer. They also found that only 19 out of those 48 patients got transplanted. Now, 25 out of the 109 patients who had elevated PSA but did not have a diagnosis of prostate cancer got transplanted. So 75.8% with a positive PSA did not receive a kidney transplant. They also found that 1 out of 430 reported deaths was directly attributable to prostate cancer. So in case this is the patient, so what happens is the patient came for a pre-kidney evaluation on 8/20/21. He got a final biopsy, which is transperineal prostate biopsy, on June 2026. Time since listing is 23 months. And currently the patient has chosen to stay inactive on the kidney transplant wait list. This is what I gathered from the urology note is in low and very low risk prostate cancer, the risk of death associated with organ failure is probably greater than the risk associated with prostate cancer related mortality. So what about management of prostate cancer in kidney transplant recipients? I selected a few studies and I tried to focus on studies that with majority of the patients who had low risk cancer, which is organ confined disease. And we found that radical prostatectomy was still the preferred treatment. For localized T1, T2 disease, prostate cancer specific mortality is similar for treated versus untreated men. Immunosuppression does not affect the risk of prostate cancer mortality for any therapy, change natural history, or alter the biochemical recurrence. The prostate cancer related death remains low. Now,
Rohan, can I ask?
Sure.
So, other than mortality, is there increased risk of having a metastatic disease with prostate cancer after immunosuppression
no,
compared to
No.
is there any data?
no, there is no increased risk of metastatic disease. The
Compared
natural history does not change at all.
with immunosuppression.
Yes, with
compared to
immunosuppression.
that?
So they also, to answer your question, they also tried checkpoint inhibitors in advanced prostate cancer, and there was no benefit of using checkpoint inhibitors. So there is a hypothesis that the T cells do not penetrate the tissue, and immunosuppression does not change your outcome.
Is there data on it? Like,
Yes, there is data. Yeah, that's what I was presenting, that
No, it's not death.
Yes.
But how about progression of disease, not
No.
just death?
There's no data. There is data actually. There's a lot of data that and immunosuppression does not influence the progression or risk of death.
Why aren't we transplanting?
I'll answer that question. So it's the question. The answer depends on different centers. Some centers, I think, the insurance would not pay if you have not gotten them evaluated through urology. And then it's individual, it's like an individual opinion also at other centers. But, the outlook is changing. That's what I was trying to get to.
And
Yes.
part of the evaluation, they doing free and total PSA to sort of, rather than do
Right.
or MRIs of the
Right.
prostate?
I was coming to that. Yes, I was coming to that. Yes, absolutely.
Well, I have a question.
Yeah, sure thing.
So regarding immune suppression, there is an interesting paper. I don't know if you come across these. published in AJP by Doris and Jeff from Hopkins, they did a pharmacy claims data study, and interestingly, in this unique finding, they associated sirolimus with increased prostate cancer post-transplant. Have you come across that?
I have read it somewhere, but it's a very old data.
Right.
Also, they found that the risk of death was higher in that cohort where you tried sirolimus,
Well,
right?
in,
So
in
yes.
most papers and even in
Correct.
in
which is
in-
contradictory to the mechanisms which I am going to talk about. Yes.
Yeah, but the thing is, the immunosuppression here, I think by default will have been calcineurin inhibitor mycophenolate, because it's not common to our people, so
Correct.
sirolimus might not be represented in. most
Right.
of
No,
other
the
studies.
the baseline characteristics did not differ based on
Right.
immunosuppression.
But
Um,
regarding the mortality of
But-
Hector, that is another story.
But the problem was that fewer than 30% of patients were on mTOR inhibitors
Yeah.
to begin with.
Exactly.
Yes. Again, so are there any molecular prognostic tests in prostate cancer? So what they did was through radical prostatectomy samples, they identified genes that can predict adverse pathology, which is PT3 disease, which is a surrogate for aggressive prostate cancer. So phase 3 trials are still underway, but two tests are available to order, which is one is the genomic classifier Decipher, and the second one is the genomic prostate score. And this is used to assist in risk stratification to determine if you want to choose surveillance versus treatment. The advantage with the genomic classifier is that it could be done on the initial in the initial transrectal biopsy. So again, there is validation of Decipher in this study. All I wanted to say is, the score is from 0 to 1. So based on a score, you can attain a very high negative predictive value. So for a score of 0.2, you can say with a lot of confidence that this particular cancer is not going to metastasize. So this is a way of assisting that who you can transplant without considering radical prostatectomy. Again, this was another study which validated genomic prostate score, and it was a significant predictor of adverse pathology. Now coming to MRIs, it is known as multi-parametric MRI when you use contrast. Quite a few patients who are pre-dialysis or dialysis, we cannot give them contrast. So the MRI utilizes anatomic and functional pulse sequences, and they can be done on a 3 Tesla machine to a 1.5 Tesla machine. So we have both 3 and 1.5 Tesla machines at UF, but they predominantly use 1.5 Tesla machines, which reduces the sensitivity. Now, based on the analysis, they will analyze the peripheral zone and the transition zone, and then they'll give you a score. And this prostate imaging and reporting data system, which is your counterpart for mammogram or BI-RADS, will tell you the probability of clinically significant prostate cancer. So it helps in detection, localization, and risk stratification. Now, if a person is PI-RADS 3 and you want to increase the sensitivity of the test, you give them contrast and you get the dynamic contrast enhanced images. Sensitivity ranges anywhere between 44 to 87%, and the negative predictive value is 60 to 98%, provided you are using contrast in a 3 Tesla machine. So this can also assist you in deciding if surveillance or RP is necessary for a particular patient. Now, there are various prostate cancer risk assessment scores. The one which has been used in UF and across America is the Prostate Cancer Prevention Trial Risk Calculator. You do not need a biopsy for this. Based on the scoring, you can predict the probability of low versus high risk Gleason 7 cancer, but there is individual variability in interpreting the predictions, and it does not include MRI, but this calculator is available online. Now, moving on to case 2, there is a 67-year-old black man who's pre-dialysis evaluated for a kidney transplant in May 2021. He had a left partial nephrectomy in June 2022 for a renal mass. He got a CT without contrast, which shows post-surgical changes of left partial nephrectomy, no recurrences. Years back in 2019, he had a non-contrasted CT which showed a complex cyst with these characteristics, followed by an MRI which showed a left lower pole mass, 5.4 centimeter in maximum diameter. Post partial nephrectomy, it was a 5 centimeter clear cell tubulopapillary renal cell cancer with a ISUP grade 2 out of 4, which I'm going to talk about. Now, is this person is less than a year out post partial nephrectomy? Can he be listed for a kidney transplant is our question. So to answer that question, I will be talking about this TNM staging. I'll be focusing on only organ confined disease, again T1 and T2 cancers, which is stage 1 and stage 2 cancers. Now the Farham grade score, which is now known as the WHO score, looks at nucleolar atypia and grades these cancers post radical nephrectomy, and we are going to brush up on that as I go along. So recurrence of renal cell cancer after kidney transplantation. This is a French study, multi-center. They looked at 143 kidney transplant recipients with pre-existing RCC, 87 with RCC before and 51 after RCC initiation. 9 had genetic etiology and 3 had acquired cystic kidney disease, but most of them were solitary. This is the characteristics of the tumors. So most tumors were organ confined PT1. Most were either FG score 2 or 3. Most were clear cell RCC, and most underwent unilateral radical nephrectomy. And 111 were men with mean age of 52, and majority of the patients had a wait time between 3 to 6 years after their treatment, before which they got the kidney transplant. So what they find was there was no differences, no association between. There were 11 recurrences, and 10 deaths occurred in those 11 recurrences, and 9 were directly attributable to disease progression. So what they wanted to come to was that if you have a recurrence, your risk of death was higher. All recurrences occurred in clear cell RCC, with 11 recurrences happening if you waited more than 5 years after the last treatment before transplantation. There was no association between recurrence rates and immunosuppression, which was used in patients. Again, mTOR inhibitors were not used as much, but there were some conversions to mTOR inhibitors with advanced cancers. What were the risk factors that could predict recurrence? It was clear cell histology, it was PT2 or PT3 cancers, FG4 and FG3, and the FG scoring was an independent predictor of recurrence. Now, if you waited less than 5 years after the last treatment or more than 5 years, that was not significant in determining your recurrence rates or mortality. So renal cell cancer in kidney transplant recipients, acquired cystic kidney disease is a risk factor. Kidney disease, cystic kidney disease associated RCC is often multicentric and bilateral. Papillary tumor is the most common, followed by clear cell tubulopapillary and then clear cell cancer. Both papillary and clear cell tubulopapillary cancer lack metastatic potential. Most tumors are localized. If you have a small tumor, you have good prognosis. Both dialysis and transplant patients are at increased risk compared to the general population, and the absolute risk of renal cell cancer in kidney transplant recipients remains low. Now, what are the current guidelines? So essentially, if you have a RCC which is less than 3 centimeters, you have a grade 1 or a grade 2 tumor, or you were curatively treated, unless you had a tumor which was over 7 centimeter, you can get a transplant immediately, because the treatment of choice, particularly in tumors that are less than 4 centimeter, is active surveillance followed by partial nephrectomy. In T2 tumors, they want to wait 2 years because they did a study and they found that the incidence of metastasis at presentation was determined by the size of the tumor. So if you have a tumor approaching 7 centimeters, you had a higher incidence of presenting with metastasis at the time of diagnosis of it. Now, but what we have shown, we have seen over studies is that the overall survival was better with shorter rather than longer wait times, and observation period was not associated with cancer specific mortality. Now, there are many proposed mechanisms for cancer in ESRD patients. I just wanted to touch on the VHL gene, which has been found in both hereditary and sporadic clear cell cancers. So the gene product, which is the VHL protein, it inhibits hypoxia inducible factors. So when it is unopposed, there is stimulation of growth factors, including VEGF, causing epithelial cell proliferation and cancer. Again, we are faced with this challenge all the times, that we find these incidental cysts versus masses on CT scan without contrast. So the problem over here is, unless you have these characteristics on a non-contrasted CT, it is very difficult to determine if this is a simple cyst or a mass. So to differentiate that, you need a 4-phase contrasted CT. And the nephrogenic stage, which is 10 to 122nd after contrast, is the most sensitive in detecting renal lesion. Clear cell cancer is the most enhancing, and papillary cancer is the least enhancing. Now, comparing MRI, so contrast enhanced MRI is more sensitive to contrasted CT in indeterminate lesions. Again, clear cell cancer has more contrast enhancement than papillary cancer, and there is ongoing study with multi-parametric CT and MRI plus epidemiologic features to determine if a renal mass, to determine the renal mass subtype and the grade of RCC to avoid any biopsy or nephrectomies. So why are cancer recipients at increased risk for certain cancer? And the answer is, the reasons are multifactorial. So first, the indirect effects of immunosuppression. So immunosuppression in general, it alters the immunity and immune phenotype. So people who are immunosuppressed have low number of dendritic cells and natural killer cells, which identify virus associated cells and tumor cells, leading to reduced tumor surveillance. Now, in patients who are immunosuppressed, particularly patients, this has been seen in patients who had squamous cell skin cancer, that they had increase in immunosent T cells. So these slow T cells, because of these slow T cells, the viral and tumor immunity goes down because they don't identify as many viruses or tumor antigens. They also found that in immunosuppressed patients with solid organs cancers, in the circulation and in the tumor itself, there are increased proportion of T regulatory cells, these T regulatory cells, they suppress the effector cells and thereby they reduce the anti-tumor response. Now, direct effect of immunosuppression, most of the data is on calcineurin inhibitors. So in experimental studies, mice who were exposed to cyclosporin had increased expression of VEGF and tumor growth factor beta, leading to angiogenesis and tumor growth. In vitro and in vivo studies, calcineurin inhibitors activate the RAS-RAF signaling pathway, which causes development and progression of RCC. And there is also increased expression of interleukin cells, which leads to B cell proliferation in lymphoma patients. Now, what about the anti-neoplastic effects of mTOR inhibitors? So the mTOR pathway is upregulated in many cancers, so its inhibition can impede cancer proliferation by various mechanisms. Essentially, it causes cell arrest and apoptosis. So everolimus is recommended as an adjuvant in advanced renal cancer in general population. It is not the first line agent, and it is used in advanced cancers. Now, what about drug-specific cancer risk? Again, T cell depleting agents and anti-CD52 agents such as alemtuzumab. T cell depletion alters immunity and immune phenotype and increases your risk of virus-associated cancers, including PTLD. Campath or alemtuzumab has been associated with an increased risk of colorectal, thyroid, and non-Hodgkin's lymphoma. Azathioprine has been well studied. It increases the risk of skin cancers multiple-fold. But interestingly, there is no clinical data of any direct impact of mycophenolate in increasing the incidence of any particular cancers. Factors influencing risk of cancer, I just wanted to
I have a question. The previous slide, that's very interesting. The anti-CD52, that's alemtuzumab, right?
Right.
The increased risk of non-Hodgkin's lymphoma is very interesting. I'm saying that because in writing a manuscript, I only found another paper that was published by May from Jacksonville this January, and my manuscript that says that.
Yes.
The paper by Kirk says that it does not. So that's very interesting. I don't know where I look at that reference.
And again, other factors are, increasing time on dialysis, prior history of cancer, high CPRA, highly sensitized patients, HLA-DR2 versus 0 mismatch, and then the higher KDPI kidneys or expanded criteria donors versus living donors. Now, this is a very interesting study which linked data from transplant and cancer registries to find cancer risk with functioning allograft versus allograft failure. So they followed patients with functioning allograft and who were approaching dialysis after allograft failure to see what kind of cancers were common. And they found that there was a seesaw pattern in cancer risk. Infection and immune-related cancers were associated with graft function, whereas ESKD-associated cancers were associated with graft failure. So what are these infection-related cancers? So these are the numerous infections and the cancers that have been associated with them. So these infection-related cancers are due to loss of protective mechanism of immune surveillance under the influence of immunosuppression, which is the indirect effect. Similar oncogenic viral malignancies are observed in HIV and AIDS patients. Now, is there any role of reduction in immunosuppression in post-transplant malignancy? So there's a consensus to reduce immunosuppression after cancer diagnosis, particularly for presumed viral-related cancers, PTLD, or non-melanomatous skin cancers. But in the studies, what we have found is that there is no survival benefit to lowering immunosuppression. In this study, they found that the patients who you reduced immunosuppression, they had a higher mortality. Now, there is a bias because dose reduction is usually done in advanced cancers and the rate of rejection varies between studies. So the conclusion
Well,
is,
question,
Sure,
but
please.
just a previous clinical question. If you have a patient, which one will you reduce first? The calcineurin inhibitor or the anti-mitochondrial?
Correct. Very good question. So it is the question, the answer will depend on what I wanted to achieve. So if I were to not increase the risk of rejection, then I would probably get rid of the mycophenolate. Because then you reduce
You're
overall.
not you're saying, read, I'm just asking which one to reduce first.
Which one to reduce first? Yeah, so it would depend on what kind of cancer I would be dealing with. So if I have any association of calcineurin inhibitor with a particular cancer, then I would probably go down on the calcineurin inhibitor.
But I think most of what you've seen and what I've read, really, most of the literature points to the calcineurin as the
Correct.
the solid
Correct.
cellular basis.
Correct, but we don't want patients to reject. That's why we
Yeah,
take the CNI on. Yes, exactly. Yes, correct. So again, so the conclusion is that active malignancy is not a contraindication to listing or transplantation in a select group of cancers. Immunosuppression may not modify the natural history of certain cancers. The relative risk of cancer death after transplant should be compared to the mortality while on dialysis. The overall survival is better with shorter rather than longer cancer-free wait times in many cancers.